We are on site at the Orange County Convention Center in Orlando, Florida at the 2019 ASH annual meeting. We'll be recapping some of the top news presented each day during the meeting, and soon we'll speak with Dr. Shaji Kumar on the leading abstracts in multiple myeloma and Dr. Naval Daver on some exciting studies in acute myeloid leukemia. Welcome to OncLive News Network. I'm Gina Columbus. In chronic lymphocytic leukemia, the BTK inhibitor acalabrutinib, both as monotherapy and in combination with obinutuzumab, significantly improved progression-free survival compared with obinutuzumab plus chlorambucil in the phase 3 Elevate-TN trial. The combination also showed a tolerable safety profile in patients with treatment-naive disease. Moreover, even with a crossover for disease progression in the obinutuzumab and chlorambucil arm, there was a trend toward improved overall survival in both acalabrutinib arms. However, investigators noted that longer follow-up is needed. The frontline combination of ibrutinib and venetoclax led to high rates of undetectable minimal residual disease in the peripheral blood and bone marrow in patients with chronic lymphocytic leukemia, according to a cohort of the phase 2 Captivate study. The regimen represents an all-oral, once-daily, and chemotherapy-free option for patients, along with a safety profile that is consistent with each agent alone. A first-of-kind multi-antigen showed persistence as an off-the-shelf CAR natural killer cell in patients with relapsed/refractory B-cell malignancies. The therapeutic approach would allow for a single, standardized, scalable, off-the-shelf platform, and data support the rationale for a first-of-kind phase 1 trial as a monotherapy and in combination with CD20-targeted monoclonal antibodies in patients with relapsed/refractory B-cell lymphoma and leukemia. In B-cell non-Hodgkin lymphoma, mosunetuzumab demonstrated a tolerable safety profile and durable efficacy in patients with heavily pretreated disease in a phase 1/2b trial. Activity showed that there were complete responses in patients who experienced disease progression following treatment with CAR T-cell therapies, and the early data support a possibility for retreatment with mosunetuzumab. Pivotal safety and efficacy results from the phase 1 Transcend NHL-001 trial of alisocabtagene maraleucel showcased durable clinical activity with a favorable safety profile in patients with relapsed/refractory B-cell NHL, and efficacy was also observed among patients who were refractory, elderly, comorbid, and/or had high tumor burden. Additionally, there was a low incidence and late onset of cytokine release syndrome. In multiple myeloma, the BCMA-targeted CAR T-cell therapy JNJ-4528 delivered early and deep responses and achieved minimal residual disease negativity in all evaluable patients with refractory multiple myeloma. The treatment also showed a manageable safety profile. In a phase 1 dose-climbing trial, a bispecific CAR T-cell therapy targeting both BCMA and CD38 showed a high ORR in patients with relapsed/refractory multiple myeloma, which included a higher rate and a longer duration of stringent complete response, as well as effective elimination for extramedullary lesions. There was no neurotoxicity observed with the treatment, and cytokine release syndrome and other adverse events were managed. Finally, in a phase 1 trial, the 2+1 BCMA T-cell engager CC93269 showed a manageable safety profile and minimal residual disease negative stringent complete responses in patients with heavily pretreated relapsed/refractory multiple myeloma. The trial continues to enroll patients in the dose escalation phase. Here we are to talk about some of the leading multiple myeloma studies that are being presented at this year's ASH annual meeting is Dr. Shaji Kumar, who's a professor of medicine at Mayo Clinic. Hi, Dr. Kumar. How are you doing today?
I'm good. How are you?
I'm good. Thank you. Thank you so much for being here.
Busy meeting.
It is, yes. Just kicking off and it's very busy already.
Yes, already.
So let's first start by talking about these interim early phase results about the BCMA 2+1 T-cell engager CC93269 in relapsed refractory myeloma. So what can you tell us about the data that's been presented so far?
Right. So it's we have quite a few very exciting abstracts that are being presented from the myeloma perspective, and I think the focus of many of these have been immunotherapies. And as we know, we have seen some very exciting data with the CAR T trials. They have more patients, more longer data. We have seen some very early data from the with the BiTE technology, the AMG 420 being one of them, and that seemed to be quite exciting. Now here we have a totally different BiTE molecule, which actually has with two structures that are trying to bind to the myeloma cell. and then a CD3, which then binds to the T cell. So the hope is that this will actually be a better structure or makeup that will allow the T cells to come to the myeloma cell and kill them. And the results, it's very preliminary, very early data, but it seems to be quite promising. It's a dose expansion phase, and they have reached up to the dose I think they will go, which is 10 milligrams, and it's given weekly for initially, then every other week, and then eventually once a month. And they have seen among the patients who got the 10 milligram dose, almost 80% of those patients did respond. Granted, these are small numbers of patients. About 13 out of the 13 patients who have responded nicely to the higher dose levels. And the interesting thing also was the patients who responded, the majority of them were in a bone marrow MRD negative state. In fact, they reached that state almost by the end of the cycle 2. So demonstrating that from a proof of principle standpoint, using a biotechnology to enhance the T cell immunity against the myeloma cell is clearly working. It works effectively, it works very fast. What we don't know yet is how long will it last. And I think the longer term results, especially the expanded portion of the trial, will give us a good sense of whether these are durable responses or not. And that's going to be a key thing.
Good. Those are some great points. Thank you. So BCMA definitely seems to be a target that we're going after in myeloma. There's also the phase 1b2 CARTITUDE-1 trial that's looking at JNJ4528, also in relapsed refractory disease. So what can you tell us about this agent?
Now that is also a CAR T that is again targeted towards the BCMA. Slightly different in terms of how it's made up compared to the BB2121 product that we have a lot more data on. And the results again very early on, a handful of patients that have been treated, but the results are quite exciting. The majority, almost all the patients responded to treatment. The majority of those patients were able to get to deep responses, including complete responses and some MRD negative patients as well. And just as with all these immunotherapies, they appear to be quite early responses. Again, the follow-up is fairly short at this point, mostly 6 months around. So it's too early to say, as with other treatments, how durable these responses are going to be. But in terms of the overall response rate and the depth of response, they're certainly living up to the hype.
Definitely seems to be a theme with a lot of early but exciting data going on.
Absolutely.
Very nice. Now, how about the bispecific CAR T-cell therapy that's targeting both BCMA and CD38? There were some updates from the dose climbing trial that presented.
Right. So I think that's a very interesting concept, because we know that BCMA is a great target. We have multiple different mechanisms that we are using to go after it. Naked antibodies that are with a payload toxin, the BiTEs, and the CAR T cells. The question is, but it's very likely that if we keep going after one antigen, that may not be sufficient to give us the durable response that we really need in this disease. So going after two different antigens, we are hoping that we can actually capture a bigger portion of that clone, and hopefully we can get a much more deeper response than what we can get with just targeting one. So the results that are going to be presented this meeting again clearly shows that that's a very effective approach, and they have seen some quite durable responses, even though again, as with many of these dose escalation trials, the data set is fairly limited. But certainly, compared to what we used to see with the new drugs at phase 1 setting 10 years ago, maybe even 5 years ago, with the conventional type of therapies, this is something that's quite unheard of, the depth of response. Now we just need to figure out how to keep them there.
Very good. Great point. Now, last year we heard about the BB21217, and this year we're getting some updated results from that one. So can you share a little bit of light on what we're seeing this year?
So I think the data is holding up as what we saw last time. Again, to say, even though it's been a year since the last meeting, it's again a relatively small number of patients. The key thing with the BB2127 is it represents the next phase of CAR T approaches, because we know that the current approach to just taking some T cells and creating CAR Ts and infusing them works, but doesn't work for very long. The question is, how can you make them work longer? And one of the approaches has been to try and see, can we get more of the memory type T cells, or the T cells that are more likely to hang around for a longer period of time, and the 21-21-7 really represents one of those efforts. And the data is quite promising. You see again rapid responses, high response rate, and very deep responses.
Now, let's switch gears a little bit, and you've been very involved in the Bellini trial looking at venetoclax and multiple myeloma. So this year we're seeing some biomarker analyses that were presented. So can you discuss those analyses a little bit, and what role do you think this type of agent is going to have for these patients?
Yeah. The venetoclax has always been very exciting from a myeloma perspective because there's sound biology behind it. We know that BCL2 expression is high in myeloma cells, and going after seemed like a logical approach. And the preclinical studies validated that, which then led to the initial phase 1 study where we noticed that, yes, patients do respond, but most of the patients who responded were the translocation 11-14 patients. So the next step was adding dexamethasone to venetoclax, again based on preclinical data, which then made the response rate go up from 40% to 65% in patients with 11-14 translocation. But there was also sound evidence suggesting there's a synergy with proteasome inhibitors. So the initial trials looked at combining bortezomib with venetoclax, almost 80 to 90% response rate in the early relapses. And that led to the Bellini trial design, where we clearly, again, patients randomized to bortezomib dexamethasone versus bortezomib dexamethasone with venetoclax. The trial was overall positive in the sense the PFS was almost double, 11 versus 23 months in patients who were getting the venetoclax combination. However, there was also an increased numbers of early deaths in the venetoclax arm that led to an inferior overall survival for the group as a whole. Since then, additional work that has been done looking at subgroups. So the obvious subgroup to look at was T11-14. So there were about 15% of patients with 11-14 translocation, and in that group we clearly saw that a huge difference in the PFS, a hazard of almost 0.1, and an overall survival that did not seem to be less for the venetoclax group, or if anything there was a trend towards better overall survival. But that is only 15%. So additional biomarker analysis that was pre-planned was to look at the impact of BCL2 expression by gene expression. And if you look at the BCL2 high patient population, the benefits seem to be almost as high as what we're seeing in the 11-14 translocated patient population. So if you look at the overall group of about 40 to 45% of patients who are either 11-14 positive or BCL2 high expression, their progression-free survival is vastly superior to the with the venetoclax and compared to without venetoclax. And the overall survival did not seem to be compromised by the addition of venetoclax. So I think clearly this is early analysis, but it clearly seems like we may be able to identify a 40% or so patient population within the myeloma patients who actually could benefit with venetoclax, either by itself or more likely in combination with other drugs.
Oh, that's good. So that's looking to hopefully answer some questions.
Absolutely. We're learning more biology, and we're learning how to use a new drug.
Perfect. Thank you. Now, on Monday, we're going to hear about the Candor Trial, and that's looking at the addition of daratumumab to carfilzomib and dexamethasone in relapsed refractory disease. So what do you think we can expect to hear about these findings?
Right. So it's an interesting question that's being answered from the Candor Trial. It's one of the late-breaking abstracts. In the U.S. setting, a lot of patients are on lenalidomide maintenance when they come to the first relapse. So some of the early phase 3 trials that were done, like the daratumumab, lenalidomide, dexamethasone, or like the Pollux trial, doesn't truly apply to the U.S. population. The Candor trial does to some extent, but increasingly there's use of the second generation proteasome inhibitors in the first relapse. So this trial clearly answers the question, can we add daratumumab to carfilzomib dexamethasone and create a regimen that is without any IMiD for a patient who is relapsing on lenalidomide? So the addition of daratumumab to carfilzomib and dexamethasone almost it significantly increased the progression-free survival. The hazard ratio is almost 0.6 or so, and the carfilzomib dexamethasone arm did almost as much as we would have expected. And so there's a significant improvement in the PFS, decreased depth of or increased depth of response, and an acceptable side effect profile. Now, clearly we do see that cardiotoxicity signal even in this study. For reason we don't fully understand, that seemed to be maybe a little less with the triplet than with the doublet. Obviously that needs to be teased apart. But I think overall the results clearly suggest that the DARA, carfilzomib, lenalidomide, dexamethasone is a good, effective regimen that can be implemented in the practice once it's available.
Great. Now, a lot of our standard regimens include the 3-drug approaches, but obviously now we're looking more at a lot of quadruplet regimens. We see some Griffin study update this year, also an overall survival update from the Alcyone trial. So can you talk a little bit more about these 4-drug regimens and what we're thinking for the future?
Right. It's an interesting and challenging time because these 4-drug regimens are doing it spectacularly well, but challenging both from the cost perspective and also patient perspective in terms of the toxicity that may be associated with 4 drugs versus 3 drugs. So the Alcyone trial clearly showed that you can add daratumumab to a standard regimen like VMP in the transplant ineligible patient population and improve the progression-free survival. Dr. Mattia is going to present data suggesting that or showing that the overall survival is also significantly better with the addition of daratumumab. The Griffin trial is looking at the transplant eligible patient population, where Dr. Voorhees presents the data with the addition of daratumumab to bortezomib, lenalidomide, dexamethasone, and shows that the depth of response is clearly much better before transplant and after transplant when you use daratumumab across the entire length of therapy. This is very similar to the Cassiopeia data that was presented with the addition of daratumumab to bortezomib Taldex, and there is the Perseus trial that is pretty much the same design that is currently accruing in Europe. So I think overall, clearly we know that in the non-transplant eligible patient population with the Alcyone data, it makes all the sense that we should think about adding, using daratumumab in this setting. In the US practice, we are probably not going to be using DARA VMP, but we are going to use DARA Lendex, which already has been shown to have better PFS in the Maya trial. In the transplant eligible patient population, the question is, should we be using VRD or should we be using DARA VRD for everyone? I don't think we are yet ready to change practice because we don't even see a PFS difference yet in the Griffin trial. So I think we had to wait and see what the PFS difference shows in the Griffin trial before we really make that leap. Because it's conceivable that we can either use 3 drugs in some people, and depending upon the response of how they do, we can maybe add the 4th drug on. So there are a variety of different options that we can use to make sure the 4th drug is only given for the patient who really needs it or will benefit from it.
Definitely, really looking at that personalized approach for each individual patient.
Yes.
Yeah.
So there are phase 3 trials that are going to be starting that's going to be looking at that question.
Great, thank you. Now, looking at maintenance therapy, we've explored that with ixazomib and lenalidomide, and now there's a phase 2 trial that's comparing the 2 agents following transplant and ixazomib, lenalidomide, and dexamethasone consolidation therapy. So what's important to note about this trial?
So it is a fairly small trial. It was kind of a proof of concept in a way. Patients would get the transplant, they get 4 cycles of IRD consolidation, and then they would get randomized to either the ixazomib or lenalidomide maintenance. So I think the results shows that it's feasible to give either of them, which we knew from the respective maintenance trial. The lenalidomide is the standard of care. The tourmaline trial showed that ixazomib improves the progression-free survival by 6 months. What this trial really the focus more than the 2 different maintenance approaches, what is the role of that consolidation with both the drugs initially as well. So I think we still need to wait to see how much more benefit it has. Again, it's a non-randomized trial. It's going to answer the question of what to do, but will clearly tell you that these are all viable approaches that can be used for patients in this setting.
Great. In smoldering myeloma, we're also looking at the combination of ixazomib, lenalidomide, and dexamethasone. So how do you think that this triplet could be effective for this patient population?
So it's again, smoldering myeloma is an area of intense investigation. Now we have 2 phase 3 trials that shows that patients with high-risk smoldering myeloma benefits from some early intervention like lenalidomide and dexamethasone. And the question now that we have shown that high-risk smoldering myeloma, it's better to intervene with something rather than nothing. I think there will be a shift in the practice with more of that prevent progression type approach. But then it brings up the question, is that really the right approach? Should we just try to prevent progression, or should we just treat them like myeloma? Would that be a better approach? So there's phase 3 trial that's looking at DARA Lendex versus Lendex in the high-risk smoldering. Meanwhile, there are multiple phase 2 trials like this which are already asking the question, can we look at all these different myeloma regimens and see what we find? Obviously, it's not going to answer is Ixa-Lendex better than Lendex, but it also tells you that Ixa-Lendex is a regimen that is effective can be used in the smoldering patient population. There are other phase 2 trials looking at very intense regimens like the CSER trial that looked at KRD plus transplant that Dr. Marvi Mateo is presenting at this meeting, which clearly shows that you get almost 80 to 90% of those patients in a very good partial response. Almost 2/3 of the patients are in MRD negative state after at the end of the maintenance and consolidation. So what we are looking at is, nothing versus something. I think something is proven to be better for the high risk.
Right.
Now, that something should be just a little bit of something to keep the lid on things, or should we be just trying to treat like myeloma? Or should we be just treating them even more intensely than myeloma with the hope that we can cure the disease at an early phase? Yeah. So that's kind of what the field is moving towards.
Very interesting. Now, there is another triplet of ixazomib, daratumumab, and low-dose dexamethasone for unfit and frail patients with newly diagnosed disease. So, could you share your perspective on this regimen? And that's being explored in the phase 2 HOVEN 143 study.
Yeah, so ixazomib is a very well tolerated proteasome inhibitor. The neurotoxicity signal that we saw with bortezomib is not there, or it's much less intense. And we have looked at ixazomib in multiple different combinations in newly diagnosed and relapsed settings. People tolerate it well. So there has been a lot of interest, especially using it in the older, more frail patients, so they don't have to come to the clinic to get an injection. They can take a pill, come back once a month, and take the pill once a week. So this is part of that same effort. We already know from the Candor Trial that daratumumab, bortezomib, dexamethasone is an effective regimen. So can we take a more gentle PI and combine that with daratumumab in an older patient population? The results are going to show clearly says that it's an effective regimen. It's pretty well tolerated. So I think it's certainly something that needs further exploration.
Great. These have been great points. You just gave a fantastic overview of so much really great data being presented here this year. Are there any other abstracts that you're involved in or that you would just like to spotlight?
There are. I think it's overall there's a lot of breadth in terms of biology and treatment. We have been looking at another quadruplet. We are talking about quadruplets. There's a talk being presented by Dr. Kapoor from our group, where we looked at ixazomib, lenalidomide, dexamethasone, and daratumumab, but with the goal of dropping the dexamethasone after the first couple cycles to see if we can actually create a regimen that's effective, but without relying much on dexamethasone. And what we found was the results are pretty comparable with and without dexamethasone when we use these 4 drugs together initially, and then dropping down to 3 drugs. So I think it's feasible that we'll be looking at a reduced dose dex or dex-free regimens in the future as these new drugs come along.
Right. So really trying to limit that steroid use for patients. Interesting. Great. Dr. Kumar, thank you so much for coming here today, and we had a great time. Thank you so much for sharing so much great myeloma data.
Thank you for the opportunity.
We are here with Dr. Naval Daver, who is an associate professor in the Department of Leukemia at the University of Texas MD Anderson Cancer Center. Hi, Dr. Daver. Thank you so much for being here today.
Good, thank you.
So we're going to talk about some acute myeloid leukemia research being presented here at this year's meeting.
Sure.
So let's first start off. Of course, we've had quite a few updates in AML in this paradigm for the last couple of years. It's been really exciting.
Yep.
Let's first start on an abstract that you were the lead author on. So this is phase 1B results of venetoclax in combination with idasanutlin in elderly patients with relapsed refractory AML. So could you share your thoughts on these data?
Sure. So this is a novel combination that we developed based on preclinical synergy, and the preclinical data was done at MD Anderson, and it showed that by combining MDM2 inhibitor with venetoclax, we could avoid resistance to venetoclax, which is usually through MCL1 upregulation. And so this paper was published in Cancer Cell, quite a high impact preclinical data set, and that led to this combination trial. And the trial was designed for a very high-risk population, elderly patients above 60 with relapsed AML. So elderly patients are difficult to treat on their own, and especially if they're relapsed, it really is a big area of unmet need. And what we saw was, in general, the safety of the combination was well tolerated. The main side effects were GI, which are the known side effects with MDM2 inhibitors, because MDM2 pathway is expressed in the gut. but the GI toxicities were very manageable. There were no study discontinuations among the 50 patients, and we had only 2 to 3 grade 3 GI events, which were all manageable. So in general, we felt the safety was good. The early mortality, 30-day mortality was 5%, which in relapsed older AML is actually quite acceptable. And then in efficacy, what we're seeing is at the recommended phase 2 dose levels, we are seeing about 50% marrow remission rates. And if we look at pure CR rates, CRP rates, they're about 35 to 40%. And this is substantially higher than what we've historically got in this elderly relapse population, where response rates with chemo or other novel agents are about 15 to 20%. So we feel that these responses are significantly higher with a tolerable oral-oral combination and could fit very nicely in older relapsed AML population. It's also important that this drug, idesanutlin, is actually being evaluated in a phase 3 study in combination with Ara-C. This is the MIRO study. It was in relapsed AML, getting Ara-C alone or Ara-C plus the MDM2 inhibitor idesanutlin, and it was a 500-patient study, completed enrollment a few months ago, and we expect some of those data in the early part of next year. And of course, if they're positive, which we are hopeful they will be, we've had good experience with this drug, then the novel combination of venetoclax idesanutlin is also something that could be considered as a label expansion in the future.
Oh, very nice. Thank you.
Sure.
Just thinking a little bit about the BCL2 inhibitor, what kind of role do you really envision venetoclax having in AML? What other kind of steps would you like to see taken with it?
In general, we're seeing that venetoclax is, almost becoming central to most AML therapy. It's becoming a very important backbone. So we all know about the study with hypomethylating agents, low-dose cytarabine venetoclax, older AML, first major breakthrough to show significant response improvement as well as significant survival improvement, and has been wonderful for our older patients with AML. But we're also doing studies at MD Anderson and other sites combining it with FLT3 inhibitors. And in fact, we have a poster here that is going to be presented. Dr. Pearl is the first author, I'm the second author, combining venetoclax with gilteritinib. And in relapsed FLT3 mutated patients who have had a prior FLT3 inhibitor like midostaurin, where you would expect historical response rates, actually based on data we presented last year at ASH, of 30 to 35%, we're seeing 85% response rate. Now it's a small number, 23 patients, but we really think that this could be a major breakthrough. Similarly with IDH inhibitor and venetoclax combination, my colleague Dr. Donardo has presented. The data is very, very promising, 80% response rates. And there are other combinations combining it with chemotherapy, such as with FLAG-IDA and venetoclax, which are also showing very, very high frontline responses. So we think this is a very important drug that is a potentiator of different chemotherapies in AML, and just like the IMiDs are in myeloma, we think venetoclax will be used extensively in many subsets in AML.
That's great. Thank you so much for sharing that.
Yeah.
There's another trial that you are authored on of the antibody-drug conjugate IMGN632 in patients with relapsed refractory AML or blastic plasmacytoid dendritic cell neoplasm. So what is important to note about this agent and its activity?
This is a very different approach. We're moving from the BCL2 FLT3 IDH to a more immune-based therapy. So antibody-drug conjugates have been used extensively in AML and in ALL. There are one in each approved. We have gemtuzumab that's approved in AML, CD33 antibody-drug conjugate, and we have inotuzumab that's a CD22 antibody-drug conjugate in ALL. And there's interest to look at other targets that may be more specific and better tolerable, and one of them is emerged as potentially being CD123 in AML. So this is an antibody that goes and attaches to CD123 and delivers a toxin payload to the leukemia cells, resulting in death of the cells. And the nice thing is that the toxin used here is a chemical toxin, as opposed to gemtuzumab, inotuzumab, others where we use bacterial toxin. And we feel that the chemical toxin is less, damaging and less toxic and less collateral damage. So the phase 1 data is basically showing a response rate of about 25 to 30% as a single agent in relapsed refractory AML, which is quite good, similar, maybe a little bit better than gemtuzumab. But what's really important is that it's been very well tolerated. We don't see severe myelosuppression, which was a worry with all the antibody-drug conjugates in AML. We have seen 2 cases of VOD. Both of these were in post-transplant patients and at higher doses, which we're no longer exploring. So now the study has moved into a combination. There's a combination of IMGN with AZA and a combination of IMGN with venetoclax and a triplet of AZA, Ven, IMGN. So I think in the next year or two, we will see if this drug can potentially go all the way.
but there's a lot of work going on.
A lot
with
of
that.
stuff going on, yeah, exactly, yeah.
That's great. Now, how about this other trial that's looking at inocedenib and azacitidine in newly diagnosed patients with IDH2 mutations?
Yeah, this is a very important study. This is a randomized study looking at combination of azacitidine with the IDH2 inhibitor enasidenib versus azacitidine alone, frontline study, and this is the early kind of data release from that study. And basically what it shows is that the response rates with the combination of enasidenib, azacitidine are much, much higher than AZA alone. Response rates of 70% plus as compared to 30% or so with AZA alone, so doubling of responses, and the survival and duration of response seems to be significantly improved. So this is kind of, building on the targeted therapy strategy that's being used across solid tumors, AML, CML, others, and basically showing that if you can find a particular mutational target, add the targeted therapy to whatever standard backbone, you can dramatically improve the response rates and survival. And the next step, of course, is, well, azacitidine IDH is good, response is good, survival is good, but can we make it better by adding venetoclax, for example? And so those studies are ongoing at our center of triplets, azacitidine, venetoclax, idasanutlin. So I think in a stepwise way, we're hoping we can get to 90-95% potential 5-year survivals, even in older AML, which only 10 years ago had 15% or lower 5-year survival.
What other abstracts in AML this year are you really excited about that are being presented?
Yeah, I think there are two that are very exciting early data, but we are very hopeful of a lot of promise from these drugs. One is a drug called CD47. This is actually an immunotherapy pathway, and one of my primary areas of interest clinical research is immunotherapy in AML, which includes antibody drug conjugates, but then also using the T cells and the body's own immune system to attack cancers. And this is a macrophage checkpoint inhibitor. It is similar to what we have done in solid tumors, PD-1, CTLA-4, but those act on T cells and enhance their activity. This acts on macrophages and enhances activity. And there is a phase 1b/2 study combining azacitidine with the CD47 antibody. It's called magrolimab in both frontline older AML not fit for induction as well as frontline high and very high risk MDS. And the initial data that was shown at the EHA meeting in an oral presentation showed very high response rates, 90% complete remission, marrow complete remission, or cytogenetic remission MDS, unprecedented. With AZA alone, we would expect 30 to 40%. And even in AML, we were seeing about 65 to 68% CR/CRIs, very similar and comparable to what we saw with AZA-VEN. But in fact, the toxicity profile, again, at an early time, looks better, potentially, with this agent, less cytopenia. They do have some early onset anemia, but that is quite manageable. So all in all, we think that this is a very exciting combination. The update will be presented this year on Monday, and the response rates as well as durability seem to be well maintained. The other agent that I think is quite interesting is one that targets TP53, which is a very high-risk adverse population for which we have no clear breakthrough therapy. Even AZA-VEN, which we were very hopeful about, did not show significantly improved survival, maybe some improvement, but 7 or 8 months is the median survival with AZA-VEN in frontline TP53 AML. And there's a drug called APR that seems to directly target the TP53 folding, and that drug in combination with AZA again in frontline MDS AML is showing very high 70 to 80% responses and some improvement in survival. So we're hoping that these two new therapies will be very helpful, especially in high-risk subsets of AML like the TP53 complex cytogenetics and others.
Great. Yeah. That's great insight. Thank you so much.
Sure. Yeah.
In closing, looking back on all the updates we've had in AML over the last just few years, lots of approvals, and what do you think that the future holds 1 year from now? What do you think we'll have learned? What advancements do you expect?
I think the next year, and I know that's what we're doing in Anderson, and we've been very heavily involved in almost all of these trials that I've discussed, is understanding one is mechanisms of resistance to a lot of these drugs. Azacitidine venetoclax or low-dose venetoclax or idesa venetoclax are all very effective, better than what we used to get, but they're all non-curative at this time. Subsets may be cured, but for the general population, we do see relapses 2-year, 3-year, 4-year out. So the question is, what is driving those relapses? Can we preemptively identify them? Can we intervene early, either by single-cell sequencing or MRD monitoring, to prevent relapses and give people sequential therapies, different doublets, triplets, and improve survival? The second is selecting patients, personalized therapy. We talked about this for 20 years, but now we really have 8, 9, 10 drugs that could be used as personalized therapy. So who should, what should we give for the IDH mutated? What's the optimal? Is it a doublet? Is it a triplet? FLT3, even a bigger question, aza-ven seems to not be as effective. It has good response, but survival is not as good as a non-FLT3. So should we use a doublet with FLT3, or should we do a triplet of aza-ven gilteritinib? And those are all the trials that are ongoing. So I don't think there are too many large randomized phase 3s at this time. There is one, this is the MIRO study of idasanutlin that will read out next year, but most of the others will be biomarker driven, mechanism of resistance, a lot of updates in immunotherapy. This is the new kind of frontier that's emerging in AML, ALL in the next 3-4 years, and it's going to be exciting. Yeah.
Great. Thank you so much, Dr.
Sure.
Daver. We really appreciate you being here today and sharing all of this insight.
Thank you. My pleasure.
That's all for today. Stay tuned for tomorrow's OncLive News Network On Location, where we will sit down with Dr. Matthew Davids on chronic lymphocytic leukemia studies and Dr. Bijal Shah on some pivotal abstracts in mantle cell lymphoma and CAR T-cell therapy. Thank you for watching OncLive News Network. I'm Gina Columbus.